Hey everyone, welcome to the presentation Caring for Transgender Patients After Gender-Affirming Bottom Surgery. My name is Pombi Silverman. I use they, them, theirs pronouns, and I'm a second-year medical student here at University of Iowa, and I will be working with these two lovely humans.
Hi everyone, I'm Dr. Paige Stross. I'm a first year urology resident here at the University of Iowa. I use she, her, and hers pronouns. I'm very excited to work with you all. Thank you for joining our webinar.
Hi, and my name is Dr. Amy Perlman. I am a reconstructive urologist at the University of Iowa Hospitals and Clinics, and my preferred pronouns are she, her, hers.
So we just wanted to thank you for, taking the time to show your care and concern for our transgender and gender nonconforming population here at the Department of Urology. We are going to be talking about how to care for trans patients, how to use trans-friendly terminology, and go over the basics of some bottom surgery that we offer here in the department. So here are just some of the objectives. So like I mentioned, we'll be learning different LGBTQ terms that you'll frequently see in the urology clinic. We'll also mention practicing preferred pronouns, using proper EPIC interface, how to care for trans patients, and then we'll also go over some of the basics of gender-affirming bottom surgery as well as post-op care. But why are we discussing transgender health in the first place? UHC is a recognized leader in LGBTQ health by the Human Rights Campaign. And we also know, just from our medical education, that culturally competent care is really necessary throughout healthcare, and caring for transgender and gender nonconforming patients is no exception. And we also know that the UHC Department of Urology provides gender-affirming bottom surgery, so we really want to make sure that we're caring for our trans and gender nonconforming patients in the most appropriate way possible, with the utmost respect, and in a way where they feel like they come back to us. Before we dive fully into covering terminology, I do want to highlight some health disparities that are faced by the trans community as a reminder of why it's so important for us to educate ourselves on trans health. In 2015, the National Center for Transgender Equality conducted a report where they interviewed over 6,400 trans and gender nonconforming people. And within their section on healthcare, they did find that 19% of trans patients were refused care due to their gender nonconforming identity. We also saw 28% of respondents reporting that they were subjected to harassment in medical settings, and 2% of those people were victims of violence in doctor's office. We also see a really big gap of knowledge amongst medical providers. 50% of respondents reported that they had to teach their medical providers about trans care. And we're also seeing that survey participants reported when they were sick or injured, they postponed medical care due to discrimination or inability to afford medical care. And if medical providers were aware of the transgender patient's status, the likelihood of the person experiencing discrimination also increased. As we can see by these statistics, it's very stressful to be a trans patient in seek of healthcare. Also, we all went to medical school or got some form of medical training. We really don't want our patients to have to educate us. They came to us to get healthcare. We want to make sure that we can educate them and provide the resources that they need. I'm just going to briefly cover some common LGBTQ plus terms that you'll see. The first is transgender man or trans man, and that is someone who was assigned female at birth but identifies as a man or as a male. A transgender woman is someone who was assigned male at birth but identifies as a woman or female. Terms like non-binary or genderqueer refer to individuals who don't really fit within the gender binary. And when I say gender binary, I mean you're either male or female, boy or girl, man or woman. Some people like to identify outside of that binary or maybe fall somewhere in between man and woman. But the point is that, people aren't strictly man or woman in that case. Gender fluid follows a similar path, but the stress here is that individuals might not always present within the same gender identity. Maybe one day they choose to present more masculine, another day more feminine, somewhere in between, somewhere not even on that spectrum. But the point to really stress here is that individuals have a fluid identity that can change, and that's something to be respected. Two-spirit is a term that's used within Indigenous communities. It's a term that describes individuals having both masculine and feminine spirit. If you do not identify as Indigenous or as a part of the Native American community, I probably wouldn't use this term because that could be considered quite appropriative. And then for agender, that is a term where individuals don't feel as though they have a gender, which can, differ from some of the terms you see above. Intersex refers to individuals who have any several variations in sex characteristics, including chromosomes, gonads, sex hormones, or genitals that, according to medicine, do not fit the typical definitions for male and female bodies. Although I will say that intersex people are as common as redheads. So if you know a redhead, maybe you know an intersex person. They're not super uncommon. Cisgender is someone whose gender identity matches the sex that they were assigned at birth. So if you were assigned female at birth and you identify as a woman, then you would be considered a cisgender or a cis woman. If you were assigned male at birth and you identify as a man, then you would be considered a cis male. So I've just included a list of some phrases to avoid. Here we have some common slurs that you might see, as well as some unnecessary questions that trans people get asked quite frequently, as well as some phrases that you might avoid. Here I just included a couple slides that include stock photos of different trans folks. The reason I did is because oftentimes we don't see super diverse representation of trans folks in media. Frequently we see people like Caitlyn Jenner, and it's really nice to have a consistent face for the trans community. But she is just one of many different types of trans folks. She is white, she's able-bodied, she has a lot of class privilege, she has a lot of media exposure, but if we look here, we see a lot of different faces within the trans community, and all of these people do identify under the trans umbrella. And the reason I'm highlighting this is because it's important to realize there's not one way to look trans. Some people might be on hormones, some people might have gone surgical transition, some people might not undergo that. Still trans, still just as trans as the next person. I think it's really beautiful that we have such a diverse community and that there are many different experiences, and that's something to take into account with your patients too. No trans person is going to be the same as the next trans person. Don't have any assumptions, just treat each person like they're an individual, just as you would with any other patient. If you use Epic at the hospital, you might come across some useful interfaces as shown here. I've just taken a couple screenshots. First thing you can do is you can hover over the gender of a patient's name to learn more about their gender identity, any pronouns they use, sexual orientation, and any physical action that this patient has taken in their decision to transition, whether it be hormones or surgery. You can also update this information on gender transition in Epic. Again, here we have pronouns, any steps taken for gender affirmation, any plans, and then also we have an organ inventory to track the organs that a patient currently has, any organs that were present at birth, any organs that were surgically enhanced or constructed, and then any organs hormonally enhanced or developed. I've also included a list of different pronouns that individuals might use and highlighted some non-binary pronouns. So you might have heard they, them, theirs. That's pretty common. We also have zers, which is also another common set of pronouns. And I really encourage you to take the time to practice using these pronouns in sentences day to day. For example, if we're referring to Dr. Perlman giving presentation, we might say, Dr. Perlman is giving the presentation, or you might say she is giving the presentation because those are Dr. Perlman's pronouns. If we're talking about me giving the presentation, I use they, them, theirs pronouns. So you could say, Bombi is giving this presentation, or you might say they are giving the presentation. Again, I really encourage you to just try it out and keep practicing until it's something you get comfortable with, because we can mess up. I've messed up before, and I use they, them, theirs pronouns. It's pretty common. I wouldn't get too caught up in it. If you do make a mistake, try not to make too big of a deal out of it. I mean, we're all learning, we're all human, we make mistakes. So I've included some examples of how to correct yourself appropriately. And then I've also included an example of what not to do. And I have seen the latter example quite frequently. It might seem like you really want to express how sorry you are for misgendering someone. I would really encourage you to just keep it short and sweet and to the point, because you're embarrassed. We don't want to make it a big deal. It's best to just move on. Trust me, you'll probably thank me later. And then here I've just included another slide on preferred names and pronouns. And if you're wondering, how do I even ask someone's preferred names and pronouns because you really don't know people's pronouns when you first meet them, the best thing to do is just, introduce yourself and ask. So, for example, whenever I go and meet a new patient, I will say things like, "Hi, my name's Pombi. I'm a medical student here at Iowa. I use they, them, theirs pronouns. What's your name and what are your pronouns?" It's short, sweet, to the point. And then I've also included here an example of a clinical note for how you might write up a note about someone who is gender nonconforming. People before have asked me, what kind of patients do you ask for their name and their pronouns? And I would say try to do it with everyone, just because you don't really know anyone's pronouns when you first meet them. It might be easy to assume based on how someone looks, but we really do want to stress that, anyone can look any certain way and have any pronoun. And also, we want to create a new culture of being more inclusive, and that means asking everyone their name and pronouns. It might feel a little awkward, but if you join us in trying to change the culture here at UIHC, we would gladly appreciate it. So thank you. And UIHC does have a policy where now people's preferred names can be displayed on Epic, as I showed before, and then also on specimen labels, patient identity boards, schedule boards, etc. I've included an example here. So now I will turn it over to Dr. DeRosa, who is going to talk about some surgical options that our trans and gender nonconforming patients can undergo.
Thank you, Pombi. So I'm here to talk about surgical options that people may choose to pursue. So surgical options for trans people range from having top to bottom surgery. And so I'll explain. Top surgery refers to the top half of a person's body, bottom to the bottom half. So for trans women and non-binary trans feminine people, surgeries that they can pursue include breast augmentation, so surgical enhancement of the breasts, facial feminization surgery, so surgery that makes a face look up and appear more feminine than their face previously to the surgery, and bottom surgery, such as orchiectomy, which is the removal of the testicles. Then there are also surgeries including vulvoplasty and vaginoplasty. So vulvoplasty here at UIHC we refer to as zero depth vaginoplasty or vulvoplasty. So it's the creation of an external vulva without an interior vaginal canal, which is a very shallow canal. And then vaginoplasty, which is the creation of a full depth vaginal canal along with the vulva. So that's something that trans women and non-binary trans feminine people can choose to pursue in terms of bottom surgery options. For people who identify as transgender men or non-binary transmasculine people. For top surgery, options include bilateral mastectomy, so removal of breast tissue, which may include chest reconstruction for a more male contour of the chest, and this can be provided by plastic surgery colleagues here at university. Also, surgeries that can be offered are oophorectomy and hysterectomy, so the removal of the ovaries or the uterus. And so that's an internal procedure that people may choose to help their bodies align with their gender identity as they continue their gender transition. And phalloplasty and metoidoplasty. So phalloplasty would be the creation of a phallus, and metoidoplasty is a surgery involving surgical elongation of the clitoris. So it is more of an erectile tissue structure that's more external from the body, sort of less tucked away and more external. And vaginectomy. So this would be the surgical resection of the vagina. So these are all surgeries that transgender men, non-binary, transmasculine people can pursue in range of top to bottom surgery. And as Pombi alluded, lots of people don't have any surgery at all. So trans people come in all shapes, sizes, and colors, and lots of people choose not to pursue surgery. Some people may pursue to have top surgery but no bottom surgery, or vice versa. So you'll meet people of all stripes who may have had surgery, and so these are some of the surgeries they may have pursued.
Hi, my name is Dr. Amy Perlman. I am a reconstructive urologist at the University of Iowa, and I work closely with Paige and Pombi on these initiatives. I also work with my colleague, Dr. Bradley Erickson, and the two of us do a lot of these surgeries together. At the University of Iowa hospitals and clinics, we've performed orchiectomies, as Paige mentioned, that it includes the removal of both testicles, as well as zero-depth vaginoplasties and full-depth vaginoplasties procedures. Now, I never really learned how to do any of these procedures other than orchiectomies during my training. And since coming to the University of Iowa, I really had to start from scratch, not only learning how to do the operations, but learning the terminology. And I'll tell you, every time I'm in clinic, like Pompey and Paige have taught me so much of how I need to communicate with my patients. And every time I'm in clinic, I practice new, like different words that I'm using, different ways of phrasing things. And every day I'm learning something new. That's the beautiful thing of being in healthcare, is any of us and all of us can learn. You can, what is it saying? You can teach an old dog new tricks. Okay. So for the preoperative visits, when we see these patients, I will simply ask, what are you interested in? What types of surgeries are you interested in? And then it all depends. All these patients come in with varying knowledge of what the different options are. And so I'll say, okay, this is what we offer here. Would you like me to start from scratch? Or what is your current understanding of what each of these surgeries entail? And then I tailor the conversation accordingly. Now, in the office during that preoperative visit, it can be really tough for some of these patients, because for most of them, I've never met them before, and they're coming in and we're talking about, big surgery. And so that is the time before surgery, or before asking the patient to, pull their pants down so we can do an exam, the time in the beginning to ask the patient, how do you refer to your genital parts? And it can be as simple as that. So I might say to a patient, after I discuss all the options, okay, the next step today, if you don't mind, is for me to do a physical examination. Before I do that, how would you like me to refer to your genital parts? For example, some people say penis, vagina, vulva, scrotum, testicles, front hole, back hole, cock, penis, dick, all those things. I think it's helpful to verbalize some of those words, because once we verbalize those words, I do think that our patients feel more comfortable than mirroring those words. And then it's our job to hear what our patients are saying and to use their terminology. There are big differences between the zero and full depth vaginoplasty that we'll discuss prior to our patients getting too far in the process. There are 4 main differences. One is going to be hair removal. Now, there's no such thing as permanent hair removal, but the big options are going to be laser and electrolysis. And it really depends on the color of the genital hair, as well as the color of the person's skin, in terms of what they'll be a candidate for. The zero depth vaginoplasty procedure at the University of Iowa does not require any hair removal, whereas the full depth vaginoplasty procedure, we do require permanent hair removal for that. And that can take a long time depending on the person. And some people it can take even 10 months, which is why this process leading up until surgery can take a while for some folks. The other one is going to be bed rest. With the full depth vaginoplasty, because we use part of the scrotal skin to make the vaginal canal, and then we put a wound vac in that area, it takes several days for that graft to attach and get blood supply from the underlying tissue. And so that necessitates 5 days of bed rest for the full depth vaginoplasty, compared to the zero depth, which is going to be less. So usually about 1 day of bed rest followed by a modified bed rest. Intraoperative risks are going to be a little bit more with the full depth vaginoplasty, because we're creating a space in between the prostate and the rectum where currently no space exists. And with that, we're dissecting right on top of the rectum. So there is a small but present risk of an intraoperative complication of a rectal injury, really with the full depth vaginoplasty. And the last big difference is going to be with dilation. With the full depth vaginoplasty, that does require lifelong dilation with dilators. And what I mean by that is, initially after surgery, the dilation regimen is going to be a little bit more intense, meaning more times a day for a longer period of time. And then the further that the patient gets from surgery, that patient will not require as much dilation, but it will require dilation for the remainder of the person's life. Otherwise, that area will close down. Those are the 4 main differences. Folks, this is an incredible opportunity to change the status quo of how we care for our transgender and our LGBTQ population and community. If you don't currently feel comfortable with these terms, now is the time to practice. We all have to get comfortable. Thank you, Paige and Pombi.
So that was a brief overview of some LGBTQ plus terms that we'll see frequently in the OHC urology department, as well as a brief overview of some top surgery options, some bottom surgery options, and then a little bit more detail about the differences between zero depth and full depth vaginoplasties. I really wanted to thank Dr. Perlman and Dr. DeRosa for providing their medical expertise, as well as for our viewers for taking the time, patience, and understanding to listen and learn more about some procedures in some populations that you might have less experience with